Hey, it's Dr. David, the ENT doctor. I just thought I would do a little bit of a different talk today. I'm going to give you some insight into what it takes to become an ENT and explain my journey to how I became an airway-focused ENT and how that's actually a really unusual thing. So, to start off with, how do you get to be an ENT? Well, you got to go to school, got to get the good marks, and you got to get to university. And my university training was 6 years of education. And then after that, I did another 3 years. That was what we call basic training. And then I did another 6 years on ENT training. And then when I was finished all that, being a sucker for punishment, I continued to do yet another year focused purely on pediatric ENT. So if you want to count from beginning to end, that's 6 plus 3 plus 6 plus 1, which is quite a long time, 16 years. So that's how much time and effort it takes into becoming an ENT, and that's before you even start working in your own clinic. That's just basically to get to the end of that beginning. And then to become what I've become, which is an airway-focused ENT, is really just a matter of what you could call it luck, or realistically it's just a factor of circumstances. So the first introduction to airway from an ENT point of view actually was in the context of adults. And you have to realise I'm a little bit old now. So when I was going through, obstructive sleep apnea was not a component of ENT in the mainstay. It wasn't really on the radar at all in terms of it being an ENT-related issue. And that's really partly just historical, because at the time that when I went through, like in the children's realm, we were focusing on tonsillitis. And in the adult realm, the paradigm was basically CPAP. And there was a few people here and there across the globe who started to realise that adult obstructive sleep apnea wasn't being sorted by CPAP in certain circumstances and scenarios. And there were people who were identifying some surgical techniques and developing and refining some surgical techniques that went some way to improving the airway, and sometimes, not always, but sometimes actually curing a person of airway obstruction so they no longer had obstructive sleep apnea. And I was lucky because one of the people that trained me had happened to go over to the United States, to Stanford University, where two people called Riley and Powell were pioneering a management paradigm of obstructive sleep apnea in adults. He went over there, brought it back to the little country town that I call Adelaide, which is where I grew up and did my training. And he taught us about these things. And in the process of teaching, it was interesting because we do rotations. So I was introduced to a certain paradigm, and then I would come and do another rotation a year or two later, and things had changed. So it was a very progressive field. And there were elements there that were trial and error, as new things are when you're pioneering things. And in the process of being exposed to the obstructive sleep apnea in adults, we were then, I guess, fostered into it from a pediatric point of view. And again, this is all going back so far that this was not a normal part of ENT. In fact, I think in Australia, those of us in Adelaide were the only ones even being taught initially about obstructive sleep apnea as part of being an element of ENT. And then when it came to pediatrics, we, again, was kind of lucky, or circumstance, because one of the pediatric respiratory doctors, who are the doctors that oversee the sleep studies in children, is also an Australian leading authority and well recognised and well respected, and he worked at our children's hospital. And he had some very insightful observations that he was making with respect to the airway and children. And one of his areas of interest, which is, I guess, was what sparked mine, was the fact that there were children struggling at school who were turning up to his clinics, and he very quickly realised that these kids need their tonsils and adenoids out, which was consistent with what other people were noticing across the globe. So again, from an ENT point of view, we kind of found ourselves having to do a procedure that we're very familiar with, tonsils and adenoids, but doing it not for tonsillitis, but for doing it for airway problems. And that took a little bit of getting used to. But we quickly learned and realised that this was a great idea. The actual surgery itself is not fabulous, if we're all honest, in terms of the recovery. But the outcomes in the long term are quite remarkable. And I adopted the saying as I was going through, is that I don't save lives, but I certainly change them. I sort of change a child's life so that instead of being the kid that's going to steal your video, that's how old I am. I talked about videos back then, okay? Instead of being the child that's going to grow up to steal your video, they're going to grow up to be the person that's the judge or the lawyer prosecuting the person stealing your video. So that obviously sounds a little bit extreme as to, you know, the outcomes, but that's what the science is showing us. It's showing us that by getting these kids breathing and sleeping better, they're doing much better. And when it comes to adults, we don't necessarily have to cure their obstructive sleep apnea. We just need to relieve some elements of their airway obstruction, getting their nose clear. If they've got big tonsils, getting them out the way. If they've got a big tongue, making it smaller, to make big differences in terms of their quality of life and their general health. And sometimes it facilitates them then being able to use CPAP, because it's very hard to use CPAP if your nose is blocked. So it makes sense to get the nose unblocked. And then I sort of started to get a few tickets on myself and starting to think I was rather clever, because I started to notice all these jaw and teeth development issues going on in kids that were turning up to my clinics. And me, being the clever person that I was, thought that no one else had ever realised this, and started sort of highlighting it to people and saying, look, you know, we've got adults turning up, and the dentist has started to use mouth guards to bring the jaws forward, and started to see, well, if the jaw's smaller than adult, that must be because it didn't develop properly in childhood and adolescence. And lo and behold, we're seeing children, for whatever reason, that have breathing problems, who have got the big tonsils, the big adenoids, they're mouth breathers, who, again, for whatever reason, had the small jaw development. And it's just like, well, if that's the jaw development now and it stays like that, this is going to be an adult with obstructive sleep apnea later on. And I thought, well, you know, we've got to sort of start looking at a team approach to this. We can't just be ear, nose and throat doctors thinking that tonsils and adenoids sorts everything out. And I was right, as you know, time went by. And then the other thing I started to stumble across was that there's all these children that we see as ear, nose and throat surgeons, again, with hay fever and allergy problems. And they're getting swelling and congestion in their nose, basically another form of airway obstruction, mouth breathing, snoring, for example. And they were sort of having real troubles, and we would try the medication, nasal sprays, and where it worked, it made a huge difference to that child's well-being and so forth. And where it didn't, we had procedures that we sort of taken from adults, when we unblock adults' noses and start doing them in children, with some trepidation and concerns, but then in due course finding that those concerns didn't translate to any actual problems, getting them unblocked, and again, making huge differences. So I kind of fell into being an airway-focused ENT just by virtue of those circumstances. The other thing that really was transformational was working in the regional areas as I have done, and a dentist who was very progressive in his ways when it comes to airway management from a dental point of view, actually approached me and said, look, I'm looking for an ENT that is able to help people breathe better. Is that what you do? And I was like, that's exactly what I do. And I'd never had a dentist come and ask me this before. So this was really right field stuff. And we're talking way back in approximately 2007. Again, that's how old I am. So from that point onwards, he started sending me some patients and I started realizing that this person was actually really good at finding airway problems. And then so I started talking to some other dentists, and then other dentists started finding me through word of mouth. And it wasn't long before I was somewhat entrenched within the dental community, basically being a very strong advocate for bringing dentistry and ENT together. And in 2009, I started running education courses on ENT in Australia, which I've then taken internationally back in the day when we could do this thing called travel. And in the mainstay, the majority of people turning up to my ENT airway courses and so forth were people in the dental community, by far. They have a great, strong interest and passion in this topic, and they're very, very skilled at finding kids and adults with airway problems. So this has been a fabulous opportunity for patients to benefit, because we have, on top of the medical side of things, we have the dental team on board wanting to help their patients far and beyond the idea of just worrying about teeth. And in delving into this, what I've also then encountered is the controversies and also the animosity. So what I've realized over time is that if you're doing something different, it doesn't mean that it's wrong. But people will get their backs up and will take comeuppance to the sort of things that you're doing and espousing. And they, in doing so, usually do so based on their preconceived ideas and models and methods of judgment, without actually realising that things are changing, things are progressing, and also necessarily realising that maybe, just on the off chance, there are some things about airway problems that perhaps I might know a little bit about. I've read thousands of papers on the topic, well beyond what's in the ENT literature. I would easily add 10 to 20% to my knowledge base on airway each and every year, incrementally, just by the reading that I do and the information that I am accumulating. I've written 2 books that sell internationally on the topic, and I've signed a book deal with an international publisher with some co-authors to do a big scale book to basically work towards it being an academic textbook. These things don't happen by accident in the big scheme of things. So when I sort of look at all that and reflect on it, I also have come to realise that not through any great desire, but just by circumstance, I'm starting to become a little bit of a leader and so forth in the field of airway-focused ENT. And it's important, I think, for people to realise across the board that really is a very different type of ENT to the traditional ENT that's out there. And in doing so, it is basically led me to, I guess, basically having 3 areas where I'm frustrated. And they've all got to do with the same context of the sorts of frustrations, but just in different aspects. So my first great frustration is the lack of interaction between the medical and dental community in the mainstay. Dentists and the people in the dental team, the hygienists, the therapists, really deserve a lot of credit for their enthusiasm for learning about airway problems, for screening for airway problems, and for identifying relationships that not necessarily causal, maybe correlation, but relationships between dental findings and then the potential existence of ENT problems that someone like myself can then help alleviate, which then translates into actually improved oral health outcomes. So we can talk about things like mouth breathing and gingivitis, for example, being a perfect example of that kind of scenario. So that's my sort of first frustration. My second frustration is actually within my own medical community. My observation, again, like for example, running the courses, is that I'm trying to get out there. I'm trying to share this knowledge and be proactive. I'm not trying to keep it a secret. I'm not trying to, lock it all up and trademark it and keep it secret squirrel type stuff. I'm really trying to teach it. I'm trying to get this information out there. And it disappoints me when I see parents who come and see me who have, and this is the reality. I'm not saying this is, every parent, but, it only takes a couple each week to sort of really just get under your skin. And I do get a couple of this each week in various forms where they've asked multiple times for referrals and haven't been given referrals. Not necessarily to me, just to see an ENT. I'm just the one that they finally get one for. Or they have been told that the problem, such as airway obstruction, is something that you don't need to worry about because they outgrow big tonsils and adenoids, which we know is not necessarily true. Information such as upper airway obstruction has no effect on the child's behaviour. It's just staggering that they could be out there. The other frustration I have is the need for timeliness of intervention. And this is not a criticism of the people in the system. It's the system that's the problem, not the people in it. But in the public health system in the state that I'm in, our national ENT body has indicated that upper airway obstruction is a Category 2 problem. What that means in the way that Australian sort of classification systems of a priority means that ideally, practically speaking, as a child with upper airway obstruction should be assessed within 3 months. A lot of these children are made Category 3, which means that they're told that they can wait up to 12 months before they're seen. The science and the research shows that a child with upper airway obstruction for 6 months or more is at high risk of falling into permanent brain damage territory. And that is the science. I'm not trying to be extremist, I'm not trying to be alarmist, but that's the information that's out there. It's published knowledge, it's not me making it up, it's out there in the literature. So clearly, waiting 12 months for an appointment to see someone like myself is already too long. So these children are not being prioritised with the concerns that should exist when it comes to the problem at hand. And then the third source of frustration is with the community in general. I really wish there was a better way of changing what people know. All I can try and do is just stand on my soapbox like I'm doing at the moment and put the message out there. Kids are not supposed to snore. Kids are not supposed to mouth breathe. If you're an adult with obstructive sleep apnea and you have a blocked nose, getting your nose unblocked makes a huge difference. We don't care about tonsillitis. Tonsillitis was my 2003, ENT variation. It's 2021 as I speak. Things change. Things have changed. I really genuinely wish that we could just get this information out there. And I know that for the many people that see this on the pages and so forth that we put it on, that they will take it on board and go, yep, I knew that. You're great. I need your help. I need people to watch and listen to get a better understanding as to what this whole scenario is about. To learn and understand that not all ENTs are focused on airway. Just like I don't focus on throat cancer. I don't focus on major ear problems. I don't focus on anterior skull-base disease. They are all elements of ENT where there are people who have chosen to focus on those elements. I focused on airway, and I focused on it very, very deeply and very, very significantly. And that's my main thing. I also need to get people to understand that surgery plays a major, major role in relieving anatomical obstructions. Relieving such obstructions doesn't necessarily fix everything, but it's a big step forwards to fixing what needs to be sorted. So that's my rant, that's my rave as to airway and ENT. I can again only hope that everything I do share every now and then just makes a difference. Just one child at a time, somewhere, a parent catches a bit of information and it just leads to that child getting seen, that child getting fixed. Doesn't have to be seen by me, doesn't have to be fixed by me. I'm not here to save the world individually. I want to bring different way of obviously people perceiving upper airway obstruction, and this is the best way I can think. So thanks for your time.